know because of the role that you all played, it was difficult for us to focus on the research capacity strengthening only. We went into other areas. So I'm going to come back to all of you with some specific questions. So take note and be prepared. So there will be questions for the 2 PhD students. Then there will be a question for the VC as a partner in this process. And then, there will be questions for PhD co-supervisors for Salma and Leonard. And I just want to thank you. I've been making notes. I just love the opportunity to collaborate. You get so many ideas. There's something DVC said about having a paper writing bootcamp to close this. I've thought about, we started the series to start listing what we need to write, when we need to complete it by, but it never occurred to me that at a stage we need to bring everybody together and finish it, which I think is brilliant. It's a good idea. The other things which have come out from what you said is about the need for to improve the capacity for proposal writing, research management services, because these things are relatively new. And interestingly, there are specific grants that will allow us to do this, which we can tap into. So, this is just brilliant to have this conversation. So, before I digress too much, Zainab is prepared. So, for the PhD students, so you've had, did was that I visited the VCs of both institutions, and I said, we have this opportunity to do this. Is this a need? They said, yes, this is a need. And rather than us making an open call, we look for anybody from anywhere, let it be one of our staff. And then I want to know, if I want to do this next time, from your perspective, what we should do better, okay? So that's how we consulted. Then I told you, for this grant, we only have partial funding. The grant will cover tuition. The grant will cover one travel to Liverpool per year, and I think essentially. But the other things we want from the universities to help cover when they travel, maybe the accommodation and subsistence. That was the agreement. So I would like each party to reflect what can be done better, what approach should we use next time, did that work, how it did not work. Then for the students, you came to Liverpool intermittently to spend some time to study. Did that work? Did it help you? Back at home in the university, were you able to get that time off work to be able to concentrate as agreed? Or what should be done differently? Because both of you have said, if we had more than one student in the institution, you may be able to support each other. And it will help the university agenda to build more capacity. So that's a good idea. But then it is two ways. If you are keeping a full-time job and you are keeping a family, to do a PhD is hard. So one way to do it is to make sure when you are doing the PhD, they give you time off work. So administratively, what are the difficulties? So these are the questions, these are the hard questions. Then when it comes to the supervisors, so I think LSTN benefited as much from this as your universities, because we use the project to also train other PhD supervisors. So I was able to bring in other people less qualified, less experienced in PhD supervision to join the supervisory team for them to learn as well. So, but in your case, how have you benefited from that arrangement? And how does it help you in your university to supervise PhD students? So Uzo will make sure we do not exceed the time, but there are lots of questions. So I don't know, up to you, who wants to start?
Yeah, I think. Thank you, Professor Charles, for your very nice questions. I think starting with the selection process, at the University of Dodoma, the selection process was just. But I think the challenge really was the project came with the areas of interest that they had that were according to the project. And we were supposed to write a proposal according to those areas of interest. I think to make it more competitive in the future, I would suggest that perhaps you should open up to other ideas. Maybe perhaps give the candidate an option to present something on the project areas, but also something innovative from our own or their own perspective, what they want to research on, and then probably go from there. But otherwise, the whole process of selection of the candidates, I think, was just, and it was robust, and it was good. The partial funding. 1 minute. Okay. So so I should speed up, or I should hand over the mic. Okay, just speed up. So the partial funding came as a challenge. Because lucky for me, the University of Dodoma was willing to cover up the missing part of the funding, although I believe that the funding part had to really be adjusted in order to cover for the needs that I needed for the studies and also for the stay in Liverpool. So lucky for me also, the DVC ACT, who was here, Professor Ukina, was very flexible for me and was able to accommodate most of the aspects of the needs to accommodate the needs of the PhD study, especially the stay in Liverpool. So I'm not sure whether the flexibility that he carried out was legal, but then I hope it is, and I hope that it can be applied to others. So I hope that in the next funding, probably you could see how, because life in the UK is really expensive, and maybe there's a way in which it can be negotiated to make sure that it takes into consideration the existing policies of the university, and also see how the project can cover the parts that are not covered by the policies of the university.
Thank you.
And then living in Liverpool was helpful. Do I wish it was a longer period of time? Yes, because I see that I cover a lot more when I'm in Liverpool. Being at home, being a mother, being a wife, being a teacher, being a doctor, and a PhD student is really difficult. But having to focus on one thing for a long period of time is really helpful. And I am glad that I was able to hand over most of the administrative duties, but again, there are still things that still sneak up on you. There is no way that you can let them go. They'll just come and they'll sneak up on you. And because of the lack of human resource at the university, there is no way that you can say no to your boss, and yet you really see the deficiency that is there. So you have to cover up some of the aspects of your responsibilities as a lecturer and also as a specialist. Thank you.
Thank you so much. Leonard, if you don't mind, since she's responding to the PhD set of questions, I would like to hear Zainab's perspective too. Then we come to the supervisors. Yeah, please, can you make a note on them? I'm sorry, but because this is the best time to just take the PhD questions that Professor may ask. I'll come back to you, Leonard, because it's naturally to the supervisors next.
Okay, thank you. In terms of selection, as Professor Charles says, the universities follow the military regulation, so I don't need to talk more. So I can start on the issue of finance. It is a problem, yeah, because as Maria said, life in Liverpool is very expensive. So I think my university, it was enabled to give some funds, even it was not enough, So I have a request for them, BBC, you are here, because still I need to go in Liverpool in the subsequent 2 years for 3 months every year. So I have a request, if possible, to add more funds during this my visit in Liverpool. So the second one for the when I'm in Liverpool, when I get a chance to go to Liverpool, it was very effective and it is bringing me positive because when I go there, I meet with the different students, different workers, so we share experience and everything. And for getting a chance to participate in PGR conference in Liverpool, it built more capacity and it helped more to be innovative in this study, and you feel, I'm not alone, we are many, and I'm not alone that maybe I don't know this and this, we are many, so we share idea and we share our pain, also we share our, stress, and also it helps to share the time or the period of happiness, so it was very attractive. And for the issue of work, as you say, being a mother, being a wife, at the time I say assistant lecturer in the university, so these main roles, it could be difficult, but because I have a passion to do a PhD, and I have a passion to build the capacity and to help my community and my government in order to improve this community health in general, and to reduce this maternal, because I was very painful during when I was working at hospital to see a mother come with health fear, but unfortunately after delivery the mother is gone, so it was very painful. So I said, oh, okay, this is the time to see how can I help my government in general and my community. Because I believe that through this PhD work, after having all this, I think we could be able to encourage policymakers through Ministry of Health and other innovative and other strategies in order to change maybe the policy and everything in order to have more capacity to the healthcare workers to reduce this maternal death. So it was very nice for me, but for the in terms of work, it's very difficult, but I do it because my university, my department of School of Health and nursing department is flexible, so it's allowing me sometimes to do work and sometimes to be engaging more in my PhD work. So I thanks all. Thank you.
And the kind of support, as Maria has confessed, that the DVC Act even adjusted on so many things so that Maria can have a comfortable environment to study. So we are sure the university is giving her as much as possible. So we think of that part. But again, when I reflect on the selection process, Maria showed interest very early of having an opportunity. But again, I remember that's why she said we should give an opportunity to write on something that is maybe not strict. The selection process was so tight, and it sometimes created enemies within, because we were in the selection panel, and it became so competitive, and they went through a round of interview. The first one was submission for the certificate and the credentials to see whether they are eligible, and we received a number of them. And the two of them passed to the next round, where they were supposed to write a concept note and present in front of a panel. And the voting was anonymous within the panel. So it was, so even Maria was anxious, worried whether she would go through
And the margin of the vote was too narrow between the two. So Maria finally got the opportunity to have this scholarship. So the call was open, but was more specific to workers of the university, as it was agreed earlier. Then again, now on the question of what have we learned in the supervision process of PhD student. Now I get the picture that you may have the behavior changes sometimes so difficult. I'm so much impressed with the kind of the process of supervising or the development of a PhD student in Liverpool. The whole process, even sometimes the supervisor has no control. I don't know, the PAP, when the student is presenting to the PAP, even the supervisor is nervous. I see Professor Charles, the way he's pushing, the way he's setting time to sit down, listen to the presentation, and insisting to the student that you are going to the PAP, those kind of issues. I wish to replicate here, that's why I'm saying behavior change is sometimes so difficult. I wish to replicate what is happening in Liverpool, but sometimes I have not managed to do it, but I have learned a lot. I know Professor Charles is very busy. Sometimes I feel myself I'm busy, but when I compare myself with Professor Charles, then I say, no, this is just a drop in an ocean. So why do I don't have time to supervise this student? But it is how the supervision process is planned, how the student have given time to manage their own study. Maria is always writing her own minutes and then coming to present what we discussed in the previous meeting. And then she owned the whole process. So that kind of supervising students, actually I'm learning a lot in that process. Thank you so much.
Thanks. Can you pass it, Salma? Thank you very much. So Salma, you go ahead and reflect on the same thing that.
Thank you very much, Yusuf. I would like first to start as a Dean of School of Health and Medical Science. I'm proud to say that this project has benefited me in a way that soon I'll be welcoming Dr. Zainab in the Department of Nursing in my school. So it's a big thing for me. Another thing that I think when I started, I said that this is our first time to implement a project of this caliber for this greatness. So for us, we have learned a lot from the project management, data management. It was up and down, but we've tried. But also we have learned how to collaboration, and we got exposure to a lot of things, and then it built us a capacity. Even the team members now you can see. So I would like to say thank you, and we have learned a lot from this project. Thank you very much.
Thank you very much, Salma. If David has anything to say, that's fine on any of this.
Three things at administrative perspective. In terms of student selection for us, actually you need a headhunting in the beginning, and that's why we presented two names for you to interview. But I think we need to, next time, to have an advertisement within the school community so that everyone can have an opportunity to apply and be considered. That is one. But then second, in terms of sharing, yeah, it is true that we agreed that we'll top up on what is available from the project for our students, for our staff to study. And this has come because, firstly, it came at the point where we had already started implementing the annual budget. That means we had no chance to restructure the budget. That is one. But then second, during that year, we had very limited budget for capacity building in the university overall. But then said, okay, we have this support. We know that it was our responsibility to provide full support for her. But they say, no, currently we don't have it. But at least if she gets this ratio, then for us, better to fight hard to top up the remaining ratio so that we can have now an opportunity for her to complement and to implement her studies. So that's why we say, okay, we'll top up on what is available, but based on the existing university policies. That's why she's saying that the rates were very, 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 very low, but that is because of the existing university policies. And the disadvantage that she has is that, the same amount of money is being given to staff who is going to start, for example, in Uganda. So you can see the difference in terms of status of life between Uganda and UK. So that's the disadvantage. But anyway, that's the national policy, and it is not easy to change, but let's see what we can do. That is number two. Then number three is about the hardship and difficulties that our staff is passing through when she or he is studying while at work and taking the responsibilities of the family. Personally, I don't encourage this mode of learning, but we have been forced to do it in this way because we don't have enough teaching staff in the university. And it has happened that, of course, this is the general tendency to all universities in Tanzania, as far as I know. But I can speak on behalf of Susan, because that's where I know best. So the issue is that we have limited capacity, teaching capacity. So that means we either have to restrict staff to go for studies, or we have to agree that we have this difficult situation, but we win and we win. That's why that's what we've been doing. And that's why still she has to take some responsibilities while she's studying. So maybe in the future, when we have a full capacity of teaching staff, then definitely we will leave staff to go for studies while off duties. Thank you very much.
Thank you very much.
I just have a kind of probably comment or question, especially from those from academia. Most of the times we see a lot of studies being done in the universities without actually reflecting in the society. See findings, everything, very fantastic work, very beautiful findings, results, but they are not being translated, into policies or actions. I don't know whether there's a kind of arrangement or strategy that probably you put in place to ensure that those findings or results are being translated into policies, especially with the government. So what kind of collaboration and engagement that you have with the government to ensure that those results that students, they're bringing out from the universities are being translated? I think that's one. Then, secondly, we're talking about data management. I think I saw one of the PhD students yesterday bringing out probably 2 or 3 presentations from a single, study. I don't know whether that is acceptable, because in some clients, they call it salami slicing. When you use a single study to produce so many, publications, salami slicing. I don't know whether that is obtainable at this level. Then, thirdly,
earlier in the week, Charles talked about different measures of maternal mortality, and that relates to missing data. So it seems likely that if data management is improved in terms of health statistics, that some statistics will get worse. Not because there is a reduction in quality of care, but because there's an improvement in the quality of data collected. So I'm interested to hear views on how to manage that perception that there is likely to be of a reduction in quality, which is actually due to an improvement in the quality of data management. If that makes sense.
So, can we make notes of the questions? Any other question from anyone? Or maybe we go back to the panel.
I think the first two questions probably I can answer those ones and save the panel the stress, but I don't think it's directed at you at all. So the first one was about the challenge of getting research into practice. So I think this starts from really developing those research questions that they are relevant for, those settings, and adequate consultation is done with the key stakeholders as these projects are developed, and engagement with the potential consumers of that finding right from the beginning. And then we need to think about how we disseminate that information. Arbitrarily, so you do a study in Zanzibar, and you go and a study in Zanzibar to address a particular research question in Zanzibar, but you go to the American Society of Tropical Medicine in Boston to present it. How many people from similar settings will be there? No, it's not really meaningful. Or you decide to publish it in a journal where audience or nobody in the relevant setting can pick it up. So that's quite difficult. So I think we just need to be careful when we design. Then I think your observation about the presentations from the PhD students yesterday, I think you probably misunderstood what was happening. So PhDs are quite big undertakings where students have to make a unique contribution to knowledge. And it's expected that they should demonstrate there is a gap in the current literature before they design their studies, put in a proposal and answer specific questions to address that gap. And so the first step will be to conduct a very systematic review, which was the first session yesterday for the students. So really telling us how they arrived at, what they were trying to answer. Then the second bit of their study, I think they just focused on one objective from their PhD. A PhD is a substantial piece of work. It will have several objectives, several research questions. They just focused on one of them. So I agree with you. I think it would not be recommended that you take one small study and you cut it up into several small pieces for the purposes of publishing. That's not something we will encourage in any shape or form. But I can assure you that for these PhD students, each one of their research questions or study objective is a complete standalone in terms of publication for a substantial contribution. So that's just my comment on those questions. I think the panel can take the rest. Thank you.
Thank you. So we have a mic there, so who wants to say anything on that? Otherwise, feel free to address the question from Sarah as well around data. I'll just leave it open to anyone that wants to start. All right.
Thank you. I'd like to address the part of the implementation and policy engagements in translating the research to the practice part and into the community. I think that is a weakness of most of the Sub-Saharan African research and research output, that most of our work is not translated into action and translated into implementation. And I completely agree that there is a gap between academicians and policymakers and actual implementers of the health services. And that is a gap that we need to work on. We need to translate our research into policy briefs, translate our research into actionable information for the policymakers that they can be able to use to implement. And that is something that I have learned very well from my PhD course. One of the courses that has been given as part of the PhD is policy engagement, policy translating your research into policy briefs and also engaging policymakers in the research outputs. I think that is an important gap that we really need to work on as researchers in the sub-Saharan African countries. Thank you.
Thank you, Maria. Any? You want to say something?
Some, I think, want to respond, but to Babatunde, if you ask me, how do we call this method of translating findings into practice? Maybe in Africa, I don't know, in developing countries, if they have succeeded well, their policy briefs, their conferences, their publications, if actually they have been translated into practice. If you ask me, the same, I may be still referring to the regional medical officer when we were visiting the facility. In Tanzania, the councils, every year they prepare a comprehensive council health care plan, CCHP. They call it CCHP. And what they want to do is always coming from the facilities. Then, because they were involved in this project, he was asking, have you documented this so that it can be included in CCHP? That means involving these, the administrative in the process of research, I think could be one of the way of making sure that the translation of the findings are absorbed immediately after the research. I think that should be one of the ways. In terms of data, I think Salma was talking about the data.
You committed that already. Yeah, Salma, please. Yeah, okay.
Yeah, actually, I was not, I didn't prepare myself for the question of data management, but instead I had something to add and contribute on the first question. If you allow me, Mr. Chair. Yes, thank you. Yes, I concur with what has been responded regarding this question, the problem of research results into practice. But our colleague wants to know why there has not been such a strong link between these two in terms of implementation in most of our countries, of course, including Tanzania and Zanzibar. What I have experienced is that there are two different things. Academic outcome and demand in the political system. Demand in the political system actually normally sets its own priorities that we need to be informed about 1, 2, 3. But then sometimes we scientists or academicians, we have our own interest. And sometimes even more, if we have projects from out of the country, then it has its own interest. So you do your researches, but you find yourself finally that your results do not match with the needs of the system by that particular time. So that means for that research result to be considered into policy and to have transformed what is existing that you think is not in the right way is very difficult. So the most important thing, if you need to have your results have a direct impact into policies, then you have to focus on the existing or really hot demand of the existing system. That is very, 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 very important when you consider the interest of your research output and the interest of the system to match these two aspects. That is one. But the second, maybe I didn't get well the question.
Yeah, so Sarah, do you want to say that again? That was important.
Yeah, so I was asking for your thoughts on how to manage a perception that government may have that there's not been an improvement in something because a statistic that's measured has got worse, and it's got worse not because there's been a reduction.
There's a disconnect because public health programs are interested in the power of study that will help them change policies. And you can't change policy with a small study.
Of addressing these issues, either we decide that we want to key into what the partner has come up with into the country, or if we are going to prepare something. First of all, I think in Nigerian situation, we are flexible on both cases because of what we normally do is that we produce our annual operational plans. And those annual operational plans are robust. At the end of the day, partner comes along and says we want to key to what you have already. There's an opportunity to key in. But we are also open to realizing that innovations outside the country are possible, and those partners coming to the country may have something they're interested in. At the end of the day, we have a roundtable discussion, and we decide, okay, fine, you have this concept, okay, fine. How can we protect our interests? Okay, fine, you're interested maybe in an aspect of syphilis. Can you look at STIs altogether? You are looking at an aspect of maybe it's stable capital C. And you also expand into PPH so that there will be something for us as a country at the end of the day. So we are always open to expanding and broadening collaborations with all partners coming on board at the end of the day. We have never told any partner no. All we do is that we come to a round table and we see how we can play around with issues and resolve those issues. At the end of the day, we also have opportunities of accelerating interventions together. We give any partner that comes along access to our database, our DHIS2 platform. Partners that work in the country have access to that once they come to our Department of Research and Statistics. We are given a login access for you to see what is happening, for you to access not just your data, but the broad sections of data at the end of the day. So there are always places whereby collaborations can be strengthened to accelerate maternal health. At the end of the areas of mentoring and coaching, we have also realized that the address is lacking across the board. Yes, the QI tries to address these issues, but of course we see that there's always space for robust collaboration. Even at the national level, we do not believe that we know it all. We are always open for program management courses, program management training, and how to improve our skills at the end of it. So at the end of the day, when you talk about national level interventions, it's majorly on program management and fixing the round peg where the round peg is supposed to be, and the square peg where the square peg is supposed to be. At the end of the day, if you do not re-strategize or put up your program adequately, at the end of the day, your interventions will be frustrated at the end of it, so you won't be able to implement and bring it to fruition. Going further, looking at targets and indicators. Most times when partners come on board, they have their own targets and indicators, and the problem is that our routine data collection has a different indicator and a different measurements, numerator and denominator. So you find that the partner has to now spend so much money trying to develop their own data collection tools and the rest of it, instead of keying into what is already available and conserving resources for the main intervention. So we're always open to see how we can play around with that, resolve those issues, and move forward with policies, and also get the best for our women and our children in country. So we also look at measurable interventions whenever partners come along to us to say we want to work with you. There are some interventions at the end of the day that are more or less research purposes. It's not an intervention that is geared towards giving the best outcomes for our women and children. So at the end of the day, we try to sit down around the table, discuss about it, and see how we make sure that those interventions are measurable and we're able to assess those care for our women and our children. Thank you so much.
How Mike nicely.
Mike.
Do we have something back to the room? No? Not yet. Okay. So I'm going to give you all a little bit of a job to do. Just because we all need to participate and not doze off after our very fine lunch. I'd like you at 2s or 3s to just spend 5 minutes thinking if you were going to write a proposal about what you could do in your country to accelerate maternal and newborn health improvements. What would be your priority proposal? So just turn around to your neighbours, and I'm going to give you 5 minutes to think about that. Who would be my pianist? Could you write down these very good?
So the question was, do a proposal, what would you focus on? So we've discussed and agreed that first, we need to look at what are the strategies that can help us to implement the conception of care. We know in Kenya that conception of care is based on the
Sorry, can we all listen? We all listen to the gentleman.
But they are not well stipulated for purposes of implementation. The other issue we can look at is how can we integrate quality improvement into labor, delivery, and postpartum care, focusing on EMOC and ZIMOC. We need to look at how we can integrate quality improvement. Then we can also ask ourselves how we can strengthen an efficient and a functional referral system so that we avoid these issues of clearing and forwarding. There has to be at least a protocol, what kind of flight can be referred at what time and to when. We also need to look at strategies on how we can institutionalize PDSR at all levels and at the same time integrate quality improvement into a PDSR. Finally, we have, for purposes of implementing universal healthcare coverage, how can we work on the area around primary care networks in relation to maternal and neonatal health? How can we build the capacity of community health promoters so that they can do home visits, they can generate data into the electronic community health information system, data that we can use to make decisions? How can we build their capacity so that they can be conducting, for example, global autopsy for maternal deaths and things like that?
Thank you very much. So we've got several really good ideas already. Let's just move over here and hear from this group.
Hello, good afternoon. So, community approaches seem to be the main pivot in changing, turning around these mortality rates, and we thought that whatever activities should be directed towards behavioral changes in the community. And like the other groups have said, involving the heads of the household or male involvement and key influential people on issues regarding wrong nutrition would make a big change. But also we talked about the use of media to create awareness and increase awareness on common aspects or causes of maternal mortality causes, newborn mortality causes, and stillbirth mortalities. And also using normal community gatherings by involving healthcare workers during those times. Let's say during a funeral, during a baptism, or simple community gatherings to say something about maybe child health, neonatal health, or reproductive health, can help create behavioral change and awareness in the community, and also prioritizing education to women. It can be formal education or home education, but whatever form of education, so that to create behavioral change in the community.
Thank you very much. Maria's group. Who's going to go next? This group. It's a very productive group at the back here.
I think I've been transformed to be a Zanzibar. So I will present in case of Zanzibar. So what can we do to improve maternal and newborn health? In a group, we have said, first of all, we need to take to scale the high impact interventions. We know that we are doing a lot, and we have new findings. So if we don't take it to scale, that will be the wastage of resource and time. Again, in Zanzibar, there has been a tremendous improvement in terms of infrastructure and equipment, but the challenge still remains into the human resource. So we have suggested the optimization of human resource components and the capacity building of the existing human resource to increase the efficiency has been encouraged. But again, there has been complaint about community linkage. We need to improve the community linkage and also the referral systems, and address the 3 delays. It is still the challenge. And again, improve on the technology. I submit.
Thank you.
In addition to this, although we have an access for the community, but we have a challenge on concerning on early booking to our pregnant mother. So we are now, as our president already recognized the healthcare community health volunteers. So we will work more together in strengthening the role of community health workers to ensure the access for our pregnant women, in order to get timely health care for the better health outcome.
Thank you very much.
So we really appreciate your support. Thank you so much.
Thank you. So the next group, Salma, do you have a you're also, and the Nigerian delegation here.
So thank you so much for us to be able to improve on maternal and child health in Nigeria. I will talk on perspective of Kaduna State. We are already doing a concept that looking at the number of midwives that we have shortage of it in the state. So we tend to build the capacity of the community health extension workers because they are the ones that are really managing our facilities. So as at now, we are able to engage consultants two consultants from the teaching hospital that have harmonized the tools in the area of life-saving skills, essential care of the newborn, and integrated management of childhood illnesses, whereby we have trained more than 2,000 healthcare workers across those interventions areas, and now we have engaged mentors, and the mentors are now following up with the providers in their facilities. They are sort of in a cluster, whereby the mentors follow them to go and mentor them in the facility, and we have already linked those facilities and health workers to the community, whereby the community volunteers are also involved, and they were sensitized that this program, we have trained providers in this facility on this and that, and they are linked with those facilities, and so the community volunteers are mobilizing the women to come to the facility to access services, whereby the mentors follow in every quarter, that is after every 3 months, for them to see what they are doing and to also see how the community volunteers are making referrals to the facility.
Thank you.
And at the end of the day, they come back. We sit together with the government as well as the consultants and the mentors to really see what are the challenges in regard to mentoring, and we address going forward for the next mentoring exercise. So this is what is really happening in the Kaduna, and I think it's the same with Oyo State.
Yeah, excellent. Thank you very much.
Sorry, can I add this?
Yeah, just quickly.
I think going to look at it, the issue of teenage pregnancy, I don't know if it's serious. Okay. The issue of teenage pregnancy is on the increase. I think we do more about sensitization and creating awareness about the danger of teenage pregnancy, because we've been seeing a lot of them these days, and let them know the attendant problems that come with it. So I think that aspect probably will leverage, like I said the other time, community structures, because that is where we have more of this teenage pregnancy. So I think if we're able to up down to the barest minimum, then we have lesser problems, or probably be able to deal with the issue of maternal causes that are not favorable.
Thank you. Very important issue, teenage pregnancy. I think they've got. Is there any other groups down here, or I'm going up to the high table? Anybody else? No? So let me come back to this team here, and you share your ideas for future programs. Thank you.
Thank you so much. So we talked about, looked at the Nigerian situation, and we see that we have about 70%, to 60 to 70% of our women going for antenatal clinic, but we are having less than 40% taking delivery at our hospitals, at our health facilities. So we have to ask the question why those women are not coming back to take delivery. So any intervention that answers that question will also accelerate and improve our maternal health in the system. So it will help our women access those services which are already available. We also talk about cost of healthcare. There is a hidden cost to healthcare, even where it is stated that it is free. You understand me? At the end of the day, women have to pay for records, pay for bed, pay for this, pay for that, pay for drugs, and the rest of them. So there is in-facility costs. So one of the things we have to address is, if we say this is free, then we should make sure that even those hidden costs are not there any longer, so that it will really be free for the women. That will really, really improve, mostly because considering that most maternal death happens in rural settings. Then we looked at issues of human resource for health, as my colleagues have earlier said. The issues of human resource for health must be solved by human resource for health. We cannot try bringing up other things to solve the problem that is caused by human resource for health. Things like bringing up shoes, bringing up chips, bringing up different kind of health workers that are not really doctors or nurses or pharmacists to do the main job. At the end of the day, there are people roaming the streets, that are doctors, nurses, and pharmacists that are looking for those jobs. Employment of those individuals will help as much as possible that advocacy to those that are in charge of governance to make sure that employments are done and recruitments are done as well as employing you will also help a lot. We'll also talk about the girl-child education and community education. We know that that is very, very critical for us, even though that is not something that can be done. It has to be a change in knowledge, attitudes, and perceptions of these individuals, but it's important because of an educated young lady will know about her rights and will be able to access those healthcare services. And if those healthcare services are not provided to standard, should be able to identify those gaps and speak out for herself and access those care. So issues on girl-child education and community education is critical. They will also have issues on religion and cultural myths and misconceptions. Why is it that at certain part of the country, more people access healthcare, other part of the country, less individuals access healthcare? And at the end of the day, you find out that home delivery is pushed at certain point of the country more than other part of the country. So those religious myths and misconceptions that are holding down these women must be addressed one after the other. And this has to be addressed by both religious and traditional leaders, which these people are involved in. So when those individuals are able to speak out concerning A, B, C, D, their followers listen more and they're able to accept such. They'll have issues of post-abortion care. We should not forget about post-abortion care. Because of issues of abortion is mostly illegal in most African states. So we have people going for unsafe abortion. So where we can really do a lot of work on is the place of post-abortion care to make sure that at least even though a woman accesses abortion in an unhealthy way and unsafe way, make sure that she has the best care when it comes to post-abortion care to prevent issues of DIC, sepsis, and other health complications that may arise, such as infertility. Thank you.
Thank you so much.
Yeah, I wanted to add something. For example, 2 weeks ago, we had a meeting with the Ministry of Health. We were auditing the causes of maternal death about in Tanzania mainland. So the biggest reason was the lack of skills, especially in managing maternal and newborn emergencies. So you can find the woman has come because you have all the files from the beginning. The woman was admitted, the woman was fine. Suddenly the woman has no fetal heart rate, the woman is taken to the theater. You know, IUFD has a risk of DIC. The woman has a placenta previa, regardless of the degree, the woman is taken for cesarean section. So everything is cesarean section. So the skill even to say, this woman can deliver normally, this cannot, are really crucial in preventing this. So in the human resource, we have really to work on the skill. But when now I touch the skill part, I touch my other part of academic institution, the pre-service training. So I think in the next part, let me spare for it, but the skills of maternal and newborn emergencies is very vital because if we train the community, they have to come to the facility. And when they reach, there is no that skilled personnel, it still can't work. So maybe we'll discuss and see the way forward. Thank you.
Thank you so much. I think give yourselves all a big clap for all your brilliant ideas. So we've heard a lot about the community and including the community and the gap, filling the gap, which might be partly an education gap or a cultural gap, and why women go to antenatal care but may not attend for intrapartum care. So that's a big research question that we can ask and answer in our various countries. And we thought about the human resources issue. That's the health systems issue, isn't it? How do we go about addressing that problem? And it is an enduring problem. And you know, I started with LSTM as a volunteer in 2007, long before I actually worked at LSTM. But the first place they sent me to was in Malawi. And we went to visit the local labour ward because we wanted to understand the context of the people that we were teaching this EMOC to. There were 8 women in labour. Some of them were just on the concrete floor. They didn't even have a mattress, let alone a bed. And there was one midwife on duty for these 8 women. And I remember saying, oh my goodness, I'm so sorry. Is it because we're running this training course that you've only got one midwife? See how naive was I? And they said, oh no, it's always like this. So that one midwife was trying on her own and failing to resuscitate what was effectively a stillborn baby. And all the other women were just labouring with no attention, no monitoring. What could this one midwife do with 8 women? And at the same time, the government of Malawi had had a big push to bring women into the facilities to deliver and away from the traditional birth attendants. And yet, what were they getting in those facilities? I don't think 1/8 of a midwife was enough care. Now, I hope things have got better since that time, but there are still perhaps not quite that magnitude of problems, but maybe there are in some places. So HR is a very crucial issue in delivering quality of care. Doesn't matter how much you train somebody, they cannot devote 1/8 of their time to a labouring woman and do it well. We've heard about teenage pregnancy and post-abortion care and the needs to address that as a research priority, and issues of skills as well, and that's something we very much have focused on. For me personally, I feel I'm an obstetrician, and I think midwives address so many of the problems of maternal health, but sometimes there comes a point where the woman's problems are beyond the skill set of the midwife. And if the doctors can't deliver the skills to those very complicated patients, they'll still lose their lives. So my own interest is particularly upskilling doctors for those women who do have big complications. And I know it's not the majority of women, and that midwives are so important in preventing many women from reaching that point, but whatever we do, there still will be women who require obstetric input, and that should be quality input. And then we thought a little bit about, you touched on the next issue that we were going to discuss actually, is pre-service. I've always thought, isn't it much better to teach people the best way to do things before they learn a less good way to do things, and then you have to correct it. So how do we start with our pre-service? Are there interventions that we can be still making that will improve pre-service training for and capacity building for both community health workers, midwives and nurses and doctors? How do we address all these complex problems at pre-service level? So I'm going to ask my expert panel to address that question. Thank you.
Okay, so regarding pre-service training, whenever we talk about maternal and newborn health, it's something that is clinical that we need the hand-on skills. So it's well that they're equipped with knowledge, but also skills. Now, coming to the skills part, it seems you have to express to a very enough, they should be equipped with a very enough knowledge for them to be exposed to the clinical area. Now, how many students do you have in the class matters? You have 300 students, let's say nursing, and you are 4 maybe midwives in that university. It's also a problem because managing all these students, making sure they have at least that skill of maybe PV or doing abdominal examination is a lie because there are too many. So how many students do you have? How many staff do you have in the university? Should be really well, it's not a political thing that when a student has to go to the university, how many resources do we invest? We have a skills lab. Do we have a very well equipped skills lab for our students to learn? Do we have, we are taking this student to the clinical area. I'm the one who taught the theory part. I go with this student to the clinical part so that they can see If I say it's a head-to-toe assessment, I will do. If I say PV, I will do PV in front of my student. Do we really supervise the clinical teaching, the clinical side for this student? Because we know it's a theory and a practice. So if we fail in the practice, we'll be talking about the practice, but in the really sense, we are not equipping them the plan. That's why we will end up employing these workers who don't have the skill, and they are going to learn when the woman has been lying in the theater. So at the end, just God that make these women survive, but not you as a doctor. So to me, it's that part. First of all, the ideal number of students, the ideal number of teachers, the clinical side, we have to invest in so that make sure we really equip the necessary skills that are needed for this. And also for midwives, as Madam said here, the midwives are the ones who take who receive the woman in labor. They say, admit and at least classify this is a high risk mother or not a high risk mother. Should they call the doctor? Should this woman deliver speedy or not? So all of those are the skills. So we have really to equip them in skills before going there. And this is not a part of just university teacher. We have nurses in the clinical area. We have clinical instructors. Nurses there, doctors there are also teachers for these upcoming young specialists. So we don't like to left this work because they are maybe from UDOM or from SUSA. No. As long as you are a nurse, as long as you are a midwife, you are automatically a clinical instructor, you are automatically a teacher. So we really need to do procedurally to really equip them with these skills, because I can't tell them we have 1, 2, 3 procedures, and when they can't even follow procedure, just take the clinic class and do the PV. So we really need to do the collaborative work between the university and the facilities to really equip these students as a result, so that they can graduate with this good skill that we normally talking about. Thank you.
So also looking at pre-service, in-service training, and the dichotomy, which of them is better, which of them will help us achieve our goals and aspirations. I think both have their place. Both have their place. But more importantly, we have been emphasizing most of our interventions on in-service training. But I feel that pre-service training has been neglected a lot, and we need to start looking at in-service training before those clinicians come out from clinic, from their training, and the rest of them. It's very, very important. Why am I saying this? Because when we talk about policy development at the national level and sub-national level, example, we say hit stable K2C. At the end of the day, before you can even put it into the curriculums for the in-service training, for those that are in-service training, sometimes it takes 3-4 years before putting it in there. So you find that there's already that delay, there's already that issue, something whereby when policies are made, such as chlorhexidine gel, moving from spirits to chlorhexidine gel, that should have been immediate in-service training. Maybe put into the in-service training so that you understand the interventions can go on immediately, even while we are doing in-service training. So there is that gap, a lot of gap there. So I think pre-service training needs to be strengthened a lot so that it can also meet up the intervention. And of that, the cost for in-service training is higher than the cost for pre-service training. The cost is so much. So number one, you have to move that healthcare worker most likely away from the health facility. Now we're talking about blended trainings. At the end of the day, the health worker, the cost for both the partners and the government when it comes to finances is also higher. But at the end of the day, if it is an in-service, if a pre-service training, you find that the cost is far lower for everybody. Also, we have issues now whereby because of the lack of proper in-service training in Nigeria, we are beginning to have a greater number of iatrogenic fistulas coming up. Fistulas caused by CS, because of the clinicians coming out of the hospitals now are not that skilled. We are seeing greater number. Before now, we had fistula caused by a prolonged obstructed labor, and that is higher. So Nigeria has the highest burden in the world when it comes to authentic visitors. But now we are seeing heterogeneous visitors coming into play. So these are issues whereby we are seeing that pre-service training is getting worse, and at the end of the day, when the staff or the personnel are already in the clinic, they start making these mistakes on the patients, which is a quality of care issue, serious quality of care issue. So pre-service is also important, in-service is also important. Thank you so much.
Thank you. Today, I open up to the floor to make any comments about pre-service training. Anybody? Please do.
Thank you for your comments. My brief one is drawing from my own experience when I was a medical student. Most of the content of what we are taught were not locally relevant. So the textbooks were written by somebody from Oxford, obstetrics and gynecology from Canada, those sort of stuff. Then towards that time, some pediatricians have come together to put.
Ladies and gentlemen, good afternoon.
Good afternoon.
On behalf of the management of the State University of Zanzibar, I would like to take this opportunity again. First to say, poleni kwa kuchoka sana, and we are happy to be with you for the past 2 days, and today is the third day, which is our final day. Please allow me to recognize the presence of coordinator of this project at institutional level among institutions that are involved in implementing this project. I recognize all guests who are invited, protocol observed. Now please allow me to give this vote of thanks on behalf of the management of the university. So as we draw this enriching knowledge management and learning events to close, I stand before you with a profound sense of gratitude and optimism. Over the past few years, we engaged deeply in the implementation of the project. We have been naming this several times, but of course I mentioned the objective letter, which is very important and with the pivotal theme of improving integrated services for HIV, TB, and malaria in antenatal and postnatal care, of which its results have been deeply discussed in these 2 past days. The insights shared, partnerships fostered, and strategies developed here in Zanzibar are important stepping stones toward our shared goals of health and well-being of our nations. And for the State University of Zanzibar, we understand that the strength of the research capacity that we have gained, the strength of project implementation that we have gained, and connectivity among academicians and practitioners in health-related fields is crucial for the progress of the healthcare in Zanzibar and beyond, because through it is when we are going to engage fully in implementing research related to health that would ultimately end up in solving the problems related to health crisis in Zanzibar. So we have seen firsthand the commitment of our faculty and partners and different stakeholders to drive forward our mission of excellence in health sciences education and research as a university. So initiatives such as the NC and PNC training packages, which have probably contributed to not only equip our staff with the capacity for conducting research, but also has provided the healthcare professionals with cutting-edge knowledge and practice, and ensure that such education is rooted in our local context and needs. So this event has solidified our connections with the global health professionals, as we've just witnessed, but also with the institutions. So this all provides support to SUSA as a hub for academic and research excellence in Eastern Africa. So these discussions held and future directions chartered here will undoubtedly influence our curriculum, our research agendas, and our community engagement strategies moving forward. So in closing, I wish to express my deepest appreciation to you all for your invaluable contributions, and together we are building a legacy of health science education that is informed by global best practices and grounded in local realities. So thank you all for your dedication and partnership, and let us continue to collaborate, innovate, and educate, as well as we strive for the healthier future for Zanzibar and for the world at large. Having said that, thank you very much, na karibuni sana tena Zanzibar, na tuendelee kufanya kazi kwa pamoja.
Good. That was a very lovely, heartwarming speech. We don't have an MOH here. Yeah. Oh, yes, please. So someone prepare. You're coming next. Me? Yes, you. No.
Thank you so much, dear moderator, ladies and gentlemen. Good afternoon again. I'm here. Today is the last day. It is the first time to be here because day before yesterday I was not around here, but I'm here on behalf of Ministry of Health because my managers and the other leaders from Ministry of Health, they have another commitment, and they were in State House today. They are calling by the minister, our president. So before, I would like to first thanks Almighty God, and today on behalf of my program, IRCH program, Integrated and Reproductive Health Program, and Ministry of Health, I would like to express my sincere gratitude to all who involved in developing this course aimed at improving the quality of care provided to mother and newborn. Our programs is responsible for RAMCA services. The commission is to enhance the health outcomes for mother and newborn. We do this by ensuring that essential health care services are developed and by promoting greater awareness within the community. So we encourage pregnant women to seek early and regular pre- and postnatal care to ensure that maternal and newborn health remain as a key priority in Zanzibar health agenda. So the IRCH program is responsible here is to achieve our goal. To achieve our goal, we try to welcome different partners, including the LSTM, to ensure the quality of care. So I would like to specially acknowledge LSTM through SUSA for for their invaluable support in building the capacity of our healthcare providers. And this program, as blended learn, the method of teaching were more of practical perspective. So the provider, they were really appreciated. So what they had used just to get lecture. But for this LSTM, method of teaching was more of practical. So they were really appreciate this. So we say thank you so much. I wish to continue on this program. Then your continuing support is essential in helping us to fulfill our mission of reducing the burden of septic condition through effective intervention, and that improve health outcome and are really relevant to our communities. So we say again, thank you so much. And I can say that let us commit to reducing the maternal and newborn, to reducing maternal and newborn deaths. Thank you so much.
Marshalling the troops, and she's not going to get away. She has to come and say something. So Salma has really led the team. I used to make a joke. I said they start slow, but they finish strong. Very, very strong. I've been blown away by their commitment, their energy, and their achievement. So please put your hands together to welcome Salma to just say a few words.
Thank you very much, Professor. First of all, I would like to say that I will miss you all. I'm sure you'll miss us too. You miss Mansa, Shuena, Tamima, Amina. You miss us all. Even Salum Simba, now you know our media, Hamza. They are all here. Thank you very much. On behalf of the School of Health and Medical Sciences, I'm beyond thrilled to express our heartfelt gratitude to our incredible partners at the Liverpool School of Tropical Medicine, and also the Global Fund and Takeda to fund this project. Your unwavering support has truly been a game changer for us. Anyway, my colleagues have covered all, the BBC ARC and our partner from MOH. So I will shorten my speech by saying that this partnership is not just about capacity building or improvement of infrastructure or providing of the other resources, but it's about empowering change, building a stronger healthcare system, and creating a future where maternal and child health in Zanzibar will thrive. I know together we can sharpen this brighter and healthier for tomorrow. So to everyone who play a role in this project success, thank you very much. This is just the beginning, and we can't wait to see what more we can achieve together in the future. Thank you very much. We will miss you all.
Good. So she's kept it short and sweet. So thank you so much, Sam. So I think I'll just say the last word so that we keep the promise of 3:30. So I think we started planning this KML 8 months ago. After me and Real visited our colleagues at State University, we went back to Liverpool. I went back to Liverpool to set up several subcommittees, and all the subcommittees they've worked very hard to deliver, to support the achievement of a very successful event. Now I'm going to single out, I'm going to call some names, some people from those subcommittees, just to express my heartfelt thanks and gratitude to their incredible hard work, to bring us to where we are today. As I acknowledge everybody's contribution, but these people, I just have to do what I have to do now to single them out. From the logistics committee, where's Rosalind? Typically, so Rosalind, even when we are calling her to acknowledge, she may be outside working. So, but she's in the room. So, she works tirelessly, and, she's put in an incredible amount of effort, to work behind the scenes, contributing to lots of planning to get us here. And she's worked closely with Adacha and with close supervision from Karibu. Big round of applause to all of you. Now, the comms sub-working group. You must have all had emails from somebody called Felicia. You will just have to meet Felicia to know the amount of energy and positivity she carries. And she works to detail, incredible detail, new ideas, new innovation all the time. And she's not here, but I just want to express, my gratitude to her energy, her hard work that has contributed a lot to the success. But she also worked very closely with somebody we brought into the team to help us, who is here and who is looking at the floor right now. But Janice from Kenya has also worked with us incredibly in this successful event. So thank you so much, Janice. In the scientific committee, so some people I will just single out because they've really helped in so many ways. Sarah White tirelessly looking through all the numbers, you can imagine. So thank you so much, Sarah. Uzo was responsible for putting together, making sure that everything comes in on time, is really quality assured, all the abstracts, all the presentations put together. Martin was the one whose head I put on the chalkboard when the AV is not working and everything, and he coordinated all of that. We had a lot of input from Chris, is not here, he couldn't travel, managing all the data and helping produce a lot of the numbers from the database. Alice and Fiona. So if we're going to give the best prize for the most simple, attractive slides, you give it to them. And they are never tired when I push students to them to say, please help me look at their slides, make it beautiful, let it make sense. They will always give them time. So I thank both of them for that contribution. All members of the team have really worked hard, to make this a successful event. I think lots of ideas have come out from this meeting. There are huge opportunities to continue our collaboration. LSTM, SUSA, UDOM, there are lots of side meetings that have taken place. I know colleagues from Ministry of Health from the various countries have been having discussions. They've exchanged notes. So I think that was what we expected, that this will be catalytic. To bring together, like minds that are really interested in helping improving maternal and newborn health, and then we can live here, with those seeds sown, and develop it into something else to move the agenda forward. There's one person I want to mention who is from the Global Fund. So Nicholas Furtado. So he has been part of this program for the past 5 years, right from inception, even before 2020. He's somebody who is always available. If I text him now, 5 minutes, he's going to text a reply, even if he's busy, even if he's traveling. I'm just coming out of the plane, I will call you in 10 minutes. When you have such response from the donors, is really encouraging. Stephanie, who has also come into Global Fund supporting us of late, she's also been quite helpful. We also want to thank Takeda CSI. They have been really supportive, helping us to manage this grant and, mold it. When we agreed what we wanted to do in the year 2020, and COVID struck, and we went back and looked at what we had signed, and we said we have to do things differently. With this justification, they were flexible. So we thank them for that, and I hope that we'll see the results. Now, we have to leave behind the legacy of this program, and the only way you can leave this legacy is when you put it in black and white. So lots of the things we have learned, we need to write it up and publish. And based on the principles which we subscribe to in LSTM about equitable authorship, I think all partners will be part of this venture over the next couple of months. So you will be hearing from me what the plans are to make sure we write up all our experience and the evidence we have gathered. So finally, thanks to all the collaborating institutions, University of Dodoma, all the ministries of health, State University of Zanzibar. We thank you for your collaboration. I think this is just the beginning of everything. I would like to thank Mansab. Mansab is always smiling. He has the answer to every problem. He knows what to do. This is the kind of people I want to have in my team. Fantastic. Thank you so much, Mansab. And where's the salon? Yes, this is the comms guy. He works tirelessly, to do so many things. Taking the photographs, the video, doing the Zoom. The guy is everywhere, from morning till late. So thank you so much to you and your team for all the hard work. We really appreciate it. Thank you so much. So colleagues, so we've come to the end now. I'm sure there will be lots of photographs we can take behind this wonderful background. And I'm sure there are activities planned for the rest of the afternoon. If I don't see you before you travel, for those who are traveling far, I wish you a safe journey back home to your families. And please, let's keep up the contact and the collaboration. And then, I'm sure there are more things we can achieve together. Asante sana. Thank you.